presents the Susan G. Komen Race for the Cure, live from Hunt Valley.
All right, I have to talk. Did you get that bagel down yet?
Why do you have to call me out? I'm seeing my bagel left.
Got a five-course meal going on over here. What in the world?
She didn't share.
This guy claims to be a doctor. Do you believe him?
I know he looks official. That's from the Garrison Forest School. They have a huge team that comes out every year, and I think they had the largest team this year.
Very good. All right, doctor, here he goes. He said, what are you going to ask me? I said, well, I'm going to start off with, who are you going to vote for in November?
Ooh, it'll be a short interview.
He said, I'm going to walk off the set right now.
I almost left the set.
You thought treating cancer was tough.
Dr. Maen Farha from Union Memorial MedStar. Thanks for joining us.
Oh, you're welcome.
Good to have you out here again this year. So many doctors that we're talking to, happy to come back here because one day we're going to cure this.
I'm very hopeful, actually. These are very exciting times for breast cancer and other cancers. We have so many new tools nowadays. We have new medications. The genomic project has really started to mature. All that work that was done in the 80s is showing results now, which is a fantastic time.
You were calling this a day of hope. You wanted to break it up into four kind of departments here, would you?
If you take 100 breast cancer patients, about 60 to 70 of them would have early favorable breast cancer. The word favorable doesn't really, there's nothing favorable about it, but these are patients who do very well with just surgery, radiation, and some type of medication to prevent recurrence. These patients have a very high cure rate in the high 90s.
Okay.
Then you have a group of breast cancer patients who have a little more aggressive disease, like HER2-positive disease. We call it HER2-positive or triple-negative disease. These patients have a meaningful chance of the breast cancer showing up in the rest of the body later.
Okay.
That's where surgery and radiation won't do the trick. These patients need what we call preventative or adjuvant chemotherapy. So that group of patients also are doing very well. Their cure rate is up to the 90 or more than 90%.
That's great.
That's good.
That's fantastic.
Yeah.
The third group are patients who have locally, what we call locally advanced breast cancer. These are patients who have large tumors, many positive lymph nodes, and these tend to be aggressive disease. And these patients would benefit from chemotherapy, hormonal therapy, targeted therapies, monoclonal antibodies, etc., before the surgery.
Okay.
We shrink the tumors so that when we do the surgery, we can do less surgery and clear margins. And then they get radiation and so on. So that group of patients needed a lot of work, and now we know what to do with them. And that cure rate there is coming up to the 70s%, which is wonderful too.
Gee.
This disease would have been uniformly fatal a few years ago, 10, 15 years ago.
And so you can tell all of this when you first are diagnosed with breast cancer in terms of where they are in that scale.
Yeah, because what we do is what we call clinical staging. We put together a bunch of information from the physical exam finding, mammography finding, MRI finding, other scans, CAT scan, PET scan, and we assign to the patient kind of where do they lie in that spectrum.
Okay.
And then we fashion the treatment according to guidelines to treat that particular problem that they have.
Gee.
But you know, when you come in, you get that diagnosis and you come into the doctor's office, a lot of times I can't imagine they're hearing any of that. You know what I mean?
No.
You're just hearing, I've got cancer.
That's absolutely right. And this is where the doctor's role and all providers' role is to make the patient understand that the word cancer doesn't mean that you fall into metastatic breast cancer, which is worst kind. That's the first thing that the patient think about. Actually, the patient think about that when they hear that they need a biopsy. Although the majority of the biopsies we do are benign, but patients think, oh my God, I have cancer, and most of the time they don't.
All right, doctor, we'll keep up the good work. Is there anything like that you're reading, that you're studying, that we don't know?
Or the vaccine, too.
Yeah.
We have a vaccine, actually. We have a vaccine trial at MedStar, Union Memorial, and Good Samaritan, and Franklin Square. It's a very nice trial that enrolls the patient's immune system to hunt and fight these cells that are hiding somewhere and that might show up 2-3 years later. It is investigation and it's not proven yet.
Right.
And we do encourage patients to enroll in the vaccine trial. There are other vaccines. I think now that we have a handle on how to treat the cancer very well, I think our next focus should be on how to prevent it very effectively.
That's it.
Save so many lives.
Yeah. When that pill comes around, let me take it. All right? Gee.
Dr. Farha, thanks so much.
You're the best. Thank you, doctor. I promised him a beer last year. Did I ever pay you back on that?
No, I'm still waiting.
He won't. He won't.
Sorry. All right. I'll buy you. I'll tell you what. I'll treat you to breakfast next year at the Iron Rooster. They're coming down the road here. They'll be all right. I'll be a big plate for you, Doc.
Thank you so much, Doctor.
I think I can handle it.
All right, where are we going now, Mary Beth?